Good evening, class. We're going to spend a few minutes together tonight just talking about payment integrity and the importance of payment integrity in the healthcare environment. And it really doesn't matter whether you go to work on that side of the financial coin that focuses on the payer side, or that side of the financial coin that focuses on the provider side. You're more than likely at some point in your career going to be involved in the quote payment integrity environment. And one of the things that we need to kind of bring us everybody up to speed with is we've talked about the coding process. We've talked about how to fill out HCFA 1500, the UB04. We've talked about the role of healthcare informatics professional, HIMS on the provider side. Oh, we've talked about the life of the claim. You've got, pre-adjudication, adjudication, post-adjudication, kind of the three main phases. And we've also talked about data repositories, information warehouses, what the payer uses their information for, kind of how it's structured, what the provider uses information for, kind of how it's structured. And now we're going to move kind of into a little different area and talk about a specific functional area, let's call it, within a health plan or within the payer side of the house that focuses on payment integrity. And most health plans, with the exception of, let's say, United Health Group, are more of a functional organization structure. And if you think about it, you've got, maybe a vertical organizational structure that goes, maybe you've got the board of directors, and then you've got the CEO or the president, depending on what terminology is. And then, he or she will have direct reports, may have a CFO, a COO, a CIO, somebody that's, that focuses, on the legal side. You've got somebody in HR. So they've got multiple vertical hierarchies or vertical linkages reporting up to them in that organizational structure. Again, with the exception of some of your health plans like United Health Group, it's more of a matrix organization where you've got some vertical linkages, but you've also got some horizontal linkages when it comes to the organizational structure. And one of the things that you find in payment integrity is a couple of things that needs to be. It needs to be a centralized, independently functioning, structure within that kind of vertical hierarchy. And I've worked with health plans where it's reported up to maybe risk management, or I worked in health plans where it reported up to internal audit. Maybe it reports up to legal. Maybe it's fragmented. Maybe some pieces of it go to legal, some independent audit, some maybe go to the medical director. Just they seem to be all over the place. But from at least from my perspective, from an efficiency perspective, and since a lot of the financial goals that you find within, you find two kinds of goals within kind of payment integrity. You have kind of the unit goals, the operational goals, the kind of the functionality goals, and then you've got the financial goals. And I think that over the years, I've decided that it really makes the most sense from payment integrity to have it report up through kind of the up through the CFO side of the house, because a lot of times the CFO side of the house within a health plan is, they may have some actuarial expertise reporting up through there. They may have some analytical expertise work, reporting up through there. But the CFO is going to be the driver of a lot of these financial goals, the financial well-being of the organization or the payer or the health plan, or, again, whatever terminology you want to use. And one of the reasons that payment integrity is so important, if I look at the information that came out from the Healthcare Fraud and Abuse Control Program, and the acronym, again, everybody loves acronyms, HCFAC, in fiscal year 2022, they were, throwing around numbers. 25% of annual healthcare spending is wasteful. Can you stop and think about that? 25 cents, 25%, 25 cents of every dollar is wasteful. And then they throw out another number that somewhere 3 to 10% of the wasteful activity is driven by fraud and abuse. And again, fraud and abuse, for the most part, occurs on or is driven by the providers. You're going to have some fraud and abuse from members also, or users or consumers of the healthcare goods and services. You'll have some fraud and abuse setting out there when it comes to government grants and some foundations. And so you've got some scattered, some kind of fragmented pieces, but the majority of that 3 to 10% that's considered or categorized by the HCFAC as fraud and abuse, it's going to be driven on the provider side from one way or another. And if we start just talking about payment integrity, think about, at least I've developed kind of my own definitions and, mission statement and vision statement and, what the culture would be. And to me, the mission for a payment integrity shop or a payment integrity team or a payment integrity functional area is to maximize the probability of claims adjudicating accurately the first time and every time, to maximize internal resources and operational efficiencies, and to minimize abrasion for covered members and providers. Makes sense to me, especially given what I've seen in healthcare. I think the mission is typically a statement that indicates why a organization, functional area, component of a given organization exists. And I think that's why payment integrity exists. You want that claim, you want the probability of all claims to be as high as possible in that they process correctly the first time, every time. Then the vision, kind of where I see payment integrity going forward, is to assist the health plan in becoming the health plan of choice for commercial groups. Now we're talking about the employer groups, talking about individual members, talking about small groups, government groups, talking about Medicare, Medicaid, TRICARE, DOD, and participating providers in any given market. So the vision, as I see it, is payment integrity through the, maximization of accurate claims adjudication drives the health plan forward so that they become the health plan of choice. Individuals that are purchasing benefit plans through the health plan, they want, to view that health plan as the plan of choice because they have respect and they feel like that the health plan is looking after the best interest. On the participating provider side of the house, you want them to feel like that they want to be a part of that particular health plan's provider network because it's going to drive membership their way, it's going to drive business their way, it's going to provide them a sense of, at least the perception, that the health plan is going to do everything possible to ensure that they are accurately paid every time they submit that claim. And then lastly, you kind of throw some culture in there, and at least the culture I've tried to foster when it comes to payment integrity teams or payment integrity shops, it's to maximize member satisfaction and utility via transparency and education, and to optimize an employee's human capital and, again, training and education for the health plan. So as far as a culture, the kind of the thread that runs through, at least my view of a culture, is training and education. I want to maximize that human capital of every employee that works on the payment integrity team. And I also want to maximize through the work we do the member satisfaction and utility. And I want to do all of this through transparency and training and education. The functional components of a payment integrity team, at least again from my viewpoint or from my, I guess, perception or perspective, is um, I'm gonna lump the first piece and just call it fraud, waste, and abuse. So within that umbrella of fraud, waste, and abuse, so basically I've got with the components of a payment integrity team, at least the way I try to line them out, I've got fraud, waste, and abuse, I've got other party liability, I've got medical economics or medical informatics. I've got operational metrics and optimization, and that's going to be kind of my reporting arm. My medical economics team it's going to be those analysts, those data scientists, those uh, medical informatics type professionals that are going to help this team identify potential opportunities to increase the probability of accurate claims adjudication. My operational metrics and optimization team, and I kind of join them at the hip with medical informatics, but they're going to be the group they're going to try to determine reporting capabilities. They're going to maybe be the reporting arm for state, federal, local compliance reporting, HEDIS reporting, a lot of those reporting types, but they're also going to focus on how to maximize operational efficiency. And then lastly, I'm going to have kind of a vendor partner component of it. And if I go back to the first component I talked about, fraud, waste, and abuse, I have some subcomponents under that. I have a special investigations unit, which from my perspective is going to focus on fraudulent providers that are abusing the system through aberrant billing practices. Then I've got I've got a reimbursement integrity unit, which is going to be, it's going to be more on, while SIU focuses more on non-facility, non-institutional providers, my reimbursement integrity unit is going to focus on the hospital side of the house, the inpatient, the outpatient side, the skilled nursing facilities, the ambulatory surgery centers. And they are going to be focused on waste as much as possible, with kind of the joining at the hip of SIU and RIU is where I'm going to have the abuse. So with RIU and SIU joined at the hip, SIU doing fraud, RIU doing waste, and they're going to work together on the abuse side, because if RIU identifies a provider that they're not sure about whether it's fraud or abusive billing, they're going to work with the SIU team to determine if the provider is truly a fraudulent provider, it's going to be handed off to the SIU team. If it's determined that that provider is more, well, it may not be able to prove fraud, but it's definitely abusive billing, then it's probably going to be worked more along the RIU team. And then the third piece of that fraud, waste, and abuse team is going to be what I'm going to call data governance and code editing. And again, remember when we talked about the life of the claim, you had the pre-adjudication, and then got to the adjudication piece. And as it starts working its way down through the system, the claim comes in, the provider starts working its way down through the system, you're going to hit what we called the primary clinical code editor. It's going to spin those claims through, and if claims have been unbundled or services have been billed that they shouldn't have been billed, it's going to kick out either the entire claim or it's going to kick out and deny lines on the claim. The claim's going to continue to process, continue to adjudicate, and at some point it's going to kind of pinned out, or I don't want to say pinned out in no man's land, but kind of go into a holding pattern. So it's been adjudicated, they know what the claim payment should be, but the payment hadn't gone out to the provider. And at that point, I'm going to grab those claims and go through a secondary clinical editor. And this one's going to be a really quick one too. I'm going to spin out, and within 24 hours, and for the most part, I'm going to use a vendor or a recovery partner for it. It's going to spin out, go to them, it's going to come back in. And that vendor recoverer, that recovery partner is going to say, we found another 1% of your claims that probably adjudicated incorrectly. And if I were you, I would go back and reprocess those claims and actually generate them out or reprocess them in such a way that they're accurately processed. So under the fraud, waste, and abuse kind of umbrella is one component of a payment integrity team. I've got a special investigations unit, got a reimbursement integrity unit, I've got a data governance and code editing unit. So, and again, usually those three, at least from my experience, are the most efficient from an operational perspective when they're kind of joined at the hip, when those three components are all working together. I've seen payment integrity teams where you have a single manager that manages SIU and RIU, and then another manager that manages code governance. I've also seen separate managers, one for SIU, one for RIU, and one for data governance and clinical editing. And it just all depends on the budgetary constraints and what the organizational chart looks like for a given health plan. And then the next component is what I refer to as other party liability, OPL. And I think it's that name of that component is somewhat self-explanatory, because their job is to ensure that the right party is responsible for the liability associated with paying that claim. You have functions within that. You have coordination of benefits. You have other health insurance. We've talked about motor vehicle accidents or no-fault insurance. You've talked about workers' comp. You've talked about subrogation, where people are falling at Walmart and trying to determine who's going to pay for the medical expenses. You've got mass tort, which typically looks at, and it's kind of joined at the hip somewhat with subrogation, but it focuses more on medical devices that have gone bad, with pharmaceuticals that have gone bad. And so, you got subrogation and mass tort kind of joined at the hip there. And you've got negative balances, you've got credit balances where providers have been incorrectly paid and you're trying to take money back, or members have been incorrectly paid, you're trying to take money back. And then you've got kind of a unique situation in there where you have what's called a credit balance on the provider side, where providers don't particularly like health plans looking at their books, but they will allow vendors to come in and look at their books, because providers should have their books balanced. They said, from an accounting perspective, you need to balance the books. And so these vendors will go in and help providers balance the books. And a lot of times it's because they've been paid twice for the same claim, or there's some claim, billing issues, adjudication issues, and they'll go in and help straighten those out. As I said earlier, medical economics, that's the group that's going to help generate analytical reports to complement the work that the internal payment integrity professionals are conducting to ensure that those claims are adjudicating correctly. And then again, your operational metrics and optimization team, they're going to be kind of on the back end of it, kind of the reports that are going to be used for quarterly business reviews, tracking financial goals, tracking operational goals, identifying opportunities to improve processes. And then lastly, I've got the vendor partners, and the vendor partners are going to be third-party teams of individuals, third-party companies that are going to come in and help health plans do a better job. They're either going to be supplementing or complementing the internal resources to, again, try to drive that probability level higher that those claims are going to adjudicate correctly. When we're talking about, at least on the health plan side, you're talking about outfits like Zealous and Optum and Change Healthcare, Cotiviti, Multiplan. There are a lot of them out there that are providing these types of of information and these types of activities going forward. And right before I get into like really down in the weeds on some of these components, I want to talk just a few minutes about economics and financials of the payment integrity activities. Um, you've got you've got at least in the last position I had in payment integrity in Buffalo, we had financial reporting broken out, and the financial reporting was kind of in three columns or three sections. You had what we called cost avoidance, where we were making changes to contracts, making changes to medical management policies, making changes to the system so that it adjudicated more, accurately. Uh, Anything that we were doing, it's what's called the prepay space. So anything that we were doing in that adjudication phase that we talked about, or maybe even farther upstream, or I guess farther downstream, where you're talking about the pre-adjudication phase, to ensure that as that claim came into the adjudication phase and starts working its way down through it, that it eliminated or mitigated the probability that that claim was going to pay incorrectly, and the provider and or the member was going to be paid incorrectly, or reimbursed for those goods and services that had been consumed. So those were cost avoidance. You had to be able to track them in the system because you wanted them to be hard dollars that in a prepay space we kept from going out the door. You also had some dollars, and these more soft dollars. When again, we categorized them as savings at that point, and it was more of we knew that we were changing behaviors on providers, the way the providers billed, especially if we identified them as fraudulent providers, we got them to change the way they bill their services. Just a lot of behavioral changes on the provider side, but you didn't know that you didn't know the definitive impact of those behavioral changes. So you categorized them as savings. They were estimates. You would take maybe the year or 2 years or maybe 3 years before that you think you made the behavioral change, and that kind of established your baseline, and you assume that, like a good economist, ceteris paribus, all other things, equal, all other things unchanged. And so you assume that distribution would continue for the next year after you made the change, and you would categorize those in savings and include them into your financial reporting. And then the last one was, cash recoveries, and those were truly hard dollars in the post-pay space, happened in post-adjudication dollars. Providers had already, submitted the claims, they'd been adjudicated, they'd been paid. The doctors had the money, the providers had the money, or in some cases you had incorrectly reimbursed members for services they'd paid out of pocket. And it was dollars that you had to physically go out and claw back, either from members or providers. So those were considered cash recoveries. One of the other things that we do in payment integrity activities is we try to negotiate cost-effective vendor contracts. If we are outsourcing services to third-party vendors, recovery partners, again, kind of what nomenclature you feel most comfortable with, then we would make sure that we negotiated those cost-effective contracts. From a financial perspective, you could look and set your goals based on either net dollars that you had brought back in, or you could set them up, based on a lot of different, I guess, methodologies or financial descriptors. But what I found over time is maybe having a financial goal based on per member per month. How many dollars you have recovered on a per member per month basis. You can have a per member per year basis and then divide it into per member per month if you wanted to. But it took into account not only dollars going out the door, but it took into account impacts to the system, shocks to the system, if you want to call them shocks to the system, such as the COVID years, 2020, 2021. It also took into account membership, because if there was a shock to the system and your membership declined and you had a decline in financials, the net financials you recovered, you can still make those adjustments because you're dividing it by the number of members. Talk about we're always on the payment integrity side. We do a lot. The payment integrity activities go a long way into what they call bending the healthcare trend, and you want to positively bend that healthcare trend. But it's not just payment integrity. Joined at the hip with payment integrity, you should have network management, medical management when it comes to bending that healthcare trend. And as we bend the healthcare trend, in other words, try to reduce that healthcare trend year over year, we're starting to do, you started doing work with other functional areas and what they called affordability objectives. And these affordability activities, you would determine a potential activity or a potential strategy or potential, policy and procedure, and then you would tie financial goals to it and generate forecasts and estimations of how many dollars that affordability opportunity would be worth when it came to bending that healthcare trend. One of the other things that we're constantly looking at on the payment integrity side of the house, and to me, when it comes to payment integrity, you've got two really broad types of individuals or categories of professionals. You've got analytical types, whether it's business intelligence, actuary, medical informatics, or whatever you want to call them, and you've got clinical types. And when you're looking at both of those categories, you want to be measuring not only your marginal product of labor, but you want to be measuring your average product of labor. And you want to see both the marginal product of labor and the average product of labor go up over time. Now, it depends on, and it varies from one health plan to the next, how they calculate that product. Is it a unit-based product, such as number of medical charts reviewed, number of audits opened, or is it financially driven and dollars are the, quote, product that you're measuring on the marginal side and on the average side? Because remember, when you're looking at marginal product and average product, as long as that marginal product is above your average product will continue to increase. Think about a student in college. Okay, so you're going to school. You start as a freshman, first semester. You end up in December with a GPA for that semester of 3.0. Come back in the spring, and you end up at the end of your spring semester, and your GPA is a really good spring. Your GPA is a 3.5. 3.5 on margin. Your average starting out was, after that fall was 3.0. What do you think your average is going? What's going to happen to your average if your marginal was ahead of your average? Then at the end of that spring semester, your average is going to rise. If it happened to be below, like a 2.5, then that average is going to come down. And it's the same concept when you're dealing with marginal product of labor and average product of labor in a corporation. And as a manager of a team, or as a director of a team, or as a vice president of a team, you're going to be acutely concerned about your marginal product of labor and your average product of labor. Because at the end of the day, whether you're on the payer side, whether you're on the provider side, we are all faced with unlimited wants and limited resources. I mean, that's just the basic tenet of economics. And we're all trying to maximize operational efficiencies. And that's why there is such a focus on marginal product of labor and average product of labor. And then we're also, from an economic perspective, we're trying to develop insights into network management and medical management efficiencies and strategies. What have we found as we on the payment integrity side, as we try to maximize that probability of claims accuracy, what are we finding as we go through our day-to-day activities that might help provide, the individuals in network management or the individuals in medical management to ensure a significant increase in the operational efficiencies of multiple functional areas within that payer group or within that health plan. And again, when we're looking at the economics and financial activities of a PI team or any other, really, from my perspective, any other functional area within a health plan, not only are you looking at the basic tenet of unlimited wants and limited resources, but you're also being driven by the three pillars of economic thought: opportunity cost, self-interest, which translates into optimization. Providers want to maximize profits. Health plans not only want to maximize profits, but they're trying to minimize the cost. Think about your profit function. Profits equal revenue minus cost. So trying to maximize their profit function, they're trying to sell more benefit plans to members or employer groups or government agencies. They're trying to minimize cost by bending that healthcare trend. And then lastly, we're all making decisions at the margin. And so we'll talk about that a little more as we go through the presentation tonight or the discussion tonight. But underlying everything that I've talked about really the entire semester are especially these three tenets of economic thought, or the three pillars of economic thought. And with that, I'm going to stop for a few minutes. And when we come back, we're going to jump in and start talking about maybe a little more in depth when it comes to just some of the components that we're going to see as we work our way through I don't want to say, I can't say perfect payment integrity team, but what I consider a very functional and very operationally efficient payment integrity team. Talk to everybody in a few minutes.